morning. My name is Preston Sprenkle. I'm an associate professor of urology at the Yale University School of Medicine. Thanks for giving me the opportunity to talk to you today about updates and changes in the early detection of prostate cancer guidelines for 2024. Why do we do prostate cancer early detection? Well, I think it's important to recognize that prostate cancer is a spectrum of disease. And early detection allows for treatment, identification and treatment of aggressive cancers. The challenge remains to not overtreat indolent disease, and that's part of the guideline to help avoid identification and management of those and treatment of those patients. And really, this is for men who have opted in for prostate cancer screening. They've had the shared decision-making discussion and are prepared to evaluate the risks versus the benefits of this evaluation. Many of you are familiar with the diagram for the NCCN guidelines. There is a baseline evaluation for the early detection guidelines, a risk assessment. We're putting in a lot of different factors. So it starts with a baseline evaluation with history and physical exam, take into account family and personal histories, as well as medications, environmental exposure, as well as racial identity. The risk assessment usually consists of an evaluation, including baseline PSA and consideration for a prostate rectal examination. And also then based on age and different risk characteristics, we stratify patients' risk and what are an acceptable PSA level based on these different risk stratification. And finally, can ultimately discuss in the far early detection evaluation increased testing intervals versus advancement to further evaluation. The changes this year were not as many as we've had in some of the previous years, but some of them are pretty significant. So some of the changes include refinement of age-related recommendations. We now reference a centralized NCCN genetic risk guideline, as well as strengthening the language on use of MRI. So looking at detail in the schematic, we removed that those with a suspicious family history, so we removed suspicious and changed the language to concerning, as well as added those for a concerning personal history as risk factors for being evaluated. Also added that for younger patients, consideration of further evaluation is appropriate even for those who may have a low PSA depending on their age and other risk factors. We wanted to allow sort of clinician concern to prompt further evaluation if they felt like it was appropriate. And finally, for men over the age of 75, we've kind of gone back and forth here, and this is constantly an area of some discussion. We've, for 2024, settled on repeat testing at 1 to 3 year intervals or consider discontinuing screening if clinically appropriate. This has varied from 1 to 4 year recommendations to 1 to 2 years most recently, and we again elongated in 2024 to 1 to 3 year intervals. There also were some changes in some of the footnotes, and we'll look at those in a second in terms of baseline characteristics. So the first one is a change, is the addition, all the language is the same, but we added the link to the NCCN guidelines for genetic and family high-risk assessment. It says breast, ovarian, pancreatic, but prostate is also included there. This is a great resource, and because it will likely be updated more frequently than any of the individual guidelines, we're trying to point to this shared resource across the NCCN. Other important language dealt with Black African American individuals. The guideline removed the language that lack of access to care and other social determinants of health are associated with poor outcomes, and data suggests a role for heritable genes linked to Black African American individuals as drivers of increased risk. So this language was removed and actually changed, updated, such that the survival disparities seen in Black African American individuals are related to social determinants of health and lack of access to care, and not to race itself or differences in the frequency of tumor-acquired genomic variants. In fact, data show that Black patients who receive equitable prostate cancer treatment have similar outcomes to white patients. And therefore, there's a need for higher vigilance in this population in the form of appropriate screening and treatment. We then go into caution that earlier screening does not necessarily equate with better outcomes, but that is language that has been in the guideline. Looking at PROS D3, which is further evaluation and indications for biopsy, The big change here is related to multiparametric MRI. Seems very simple, but instead of saying we recommend multiparametric MRI, it now is the guideline and is the de facto standard of care. So multiparametric MRI, supported by category 1 evidence, is the standard in the pre-biopsy evaluation. Similar simplification was just changing to image-guided biopsy with either transperineal or transrectal approaches rather than using truss there. And also MRI targeting is preferred, though without MRI targeting is still in the guidelines, as we recognize it is not available everywhere. Also important footnote changes included really emphasizing the importance of expert MRI readers and high quality MRI imaging. There remains tremendous heterogeneity throughout the country. And also that most of the members of the panel advocate for a combined systematic and targeted biopsy approach. I know we're going to hear about that some during this conference. But the panel members also acknowledge the risk of overdiagnosis by adding systematic biopsy. So I just want to take a moment to review some of the details from sort of the course of MRI progression in the guidelines. And it was first mentioned in 2014 when we discussed that consideration can be given for high-risk men with a previous negative biopsy, and we could use MRI followed by an appropriate biopsy technique. Subsequently, MRI was not recommended, although we acknowledge that emerging data suggests MRI-targeted biopsy may increase the detection of clinically significant disease. It was later that year that Siddiqui et al. In the NIH group under Peter Pinto published their initial results looking at MRI-targeted biopsy and demonstrated improvements in or higher rates of clinically significant cancer detection. In 2017, not recommended was removed from prior to biopsy, and largely after result of that paper. Subsequently, in 2019, added some caution that negative MRI does not exclude the possibility of cancer. This was in the heels of the PROMISE paper that was published in 2017. Later in 2019, the Precision study was published, which I think in large part in 2021 resulted in what said MRI to be performed if available rather than consider, so strengthening the language. And then MRI first and multiple other studies in 2021 and 2022 really led to the recommendation in 2023 that MRI is strongly recommended. But then now, as of 2024, MRI, if available, is considered the standard of care with category 1 evidence supporting its use prior to prostate biopsy. And MRI targeting is preferred in the setting for prostate biopsy. So in summary, for the NCCN prostate cancer early detection guidelines in 2024, not just the changes, but I think, baseline DRE remains optional or really to be considered. A lot of discussion about that every year. The guidelines really emphasize the importance of access to care for Black and African American individuals, and that race does not account for the differences in outcome based on updated data. Finally, the NCCN genetic screening group is very important, and also the role of a genetic counselor. This is a great resource for anyone who is interested in genetic counseling, but also to keep an updated look on the genomic and genetic factors involved in cancer. And finally, the MRI of the prostate is considered standard of care with category 1 evidence prior to prostate biopsy. Thank you very much.